Welcome, everyone. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation. We're going to take a deep dive into DLBCL, a diagnosis to treatment of diffuse large B-cell lymphoma. In this session, Dr. John Kuruvilla, a professor of medicine at the University of Toronto, and a hematologist in the Division of Medicine, Medical Oncology and Hematology at the Princess Margaret Cancer Centre in Toronto, will provide an overview of the approach to DLBCL and provide updates on recent developments in the management of this lymphoma. Before we begin, let me introduce myself. My name is Caroline Mitchell, and I'm the Director of Community Services at the Leukemia and Lymphoma Society of Canada, and I will be the moderator of this online event today. We'd like to invite you to type your questions and comments into the Q&A box on your Zoom webinar panel throughout the presentation. An LLC staff member will monitor the questions and will read some of your questions aloud at the end of the presentation. Due to the number of participants and limited time, we may not be able to get to all of your questions. Also, please note that Dr. Kuruvilla cannot answer specific questions about a person's personal health history or status. Today's presentation, as you noticed, is recorded, therefore you'll be able to rewatch it again on our website. Next slide, please. Are you looking for specific resources or programs, but not sure where to find them? We are here to help. You can connect with a community services lead in your area to receive personalized support and get connected to resources that are available in your local area. Reach out to us by calling our toll-free number at 1-833-222-4884. Next slide, please. We invite you to visit our website at bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Next slide, please. On our website, you will find tailored information and resources, including those specific to lymphoma and DLBCL. It includes recorded webcasts, podcasts, fact sheets, animated videos, and much, much more. Next slide, please. Did you know that the LLSC has an app where you can track your symptoms and side effects and much more? You can download the free Health Manager app to help better manage your blood cancer diagnosis. It includes medication reminders, meal planners, medication and side effect trackers, plus you can provide shared access with your caregiver. This app is available for Apple and Android devices. Next slide, please. We also offer programs that can help you connect with other members of the blood cancer community. We offer a peer support program where you can connect one-on-one with a peer volunteer and/or join a virtual support group. Connect with your local community services lead in your area to learn more. Next slide, please. It is now time and my pleasure to introduce today's speaker, Dr. John Kuruvilla. We're so happy to have you with us. Dr. Kuruvilla is a professor, as I mentioned earlier, of medicine at the University of Toronto and a hematologist in the Division of Medical Oncology and Hematology at the Princess Margaret Cancer Centre in Toronto. His research interests are the development of novel therapeutics in lymphoid malignancies and incorporating translational research into clinical trials. He is the lymphoma co-chair for the Canadian Cancer Trials Group, also known as the CCTG, as well as the chair of the Scientific Advisory Board of Lymphoma Canada. We want to welcome you here today, Dr. Kuruvilla, and thank you for being with us to share your knowledge and expertise with us on our webcast.
Well, thanks a lot, Carolyn, and good afternoon, everyone. And it's great to be with you today and have some time to walk you through some of the data and information that guides management of patients with diffuse large B-cell lymphoma. And this is done particularly with a Canadian focus because that's where I live and practice. And just before we get started, so here are my disclosures. Again, our group does a lot of research with many of the companies that are developing drugs in the lymphoma space, and that's I think an important part of what our work is. But this at least gives you a sense of the companies that I've worked with in particular. Now, by way of introduction, one of the important things to look at is how common is lymphoma or non-Hodgkin's lymphoma. And so these are data from a slide looking at 2020 Canadian cancer statistics. And what you can see is non-Hodgkin's lymphoma is the 6th most common cancer in Canada. And you can see that relates to a little over 10,000 new cases per year. The red arrow unfortunately indicates that non-Hodgkin's lymphoma cases are on the rise, and that is something from a biology standpoint we're not entirely sure why that is. But like many cancers, non-Hodgkin's lymphomas are more common in people as they get older, and this might be one of the points that highlights this increasing risk of incidence. On the plus side, you can see that the mortality, the trend is going down, and we have seen major improvements in the treatment of non-Hodgkin's lymphomas. And I'll show you some of those as they relate to diffuse large B-cell lymphoma over the course of this presentation. Now, non-Hodgkin's lymphoma is an umbrella term, and it is important to highlight that lymphoma is not one disease, but also I'm sure many of my colleagues that treat breast cancer, lung cancer, prostate cancer would also make the point that these are also not singular diseases now that we have increasing genetic and other assays that are now more able to subtype patients, and we may approach treatments very differently. But in lymphoma, these differences may be quite vast because these are different diseases with different biology and very different treatments. And again, a simple way to think about how non-Hodgkin's lymphomas can be thought about is that the most common subtype that we see is diffuse large B-cell lymphoma, which is an aggressive B-cell lymphoma. When you add up other indolent lymphomas and follicular lymphoma, that represents roughly about a third. It's a little less than that. And so follicular lymphoma is the second most common type of non-Hodgkin's lymphoma that we see. And when you think about the other smattering of lymphomas that we see, they represent, again, about a third of those diseases. And this includes, again, a completely different package of T-cell, not B-cell lymphomas. And again, in the interest of time, we won't really get into that area too much at all today. Now, this is a slide I like to show that speaks a little bit about how we classify lymphoma and how pathologists and scientists like to think about this. And so on the left, what you can see is how a normal lymphocyte, how a normal B cell grows up and develops in your body. And again, these are cells of the blood and of the immune system. And you can see that along the way, they go from a more primitive cell, starting at the top there, a stem cell, and then gradually differentiate over time, and ultimately may become a B cell that produces antibodies, and then is part of the immune system that promotes long-term memory and helps you fight, as an example, against infections that you might have been exposed to in the past. What you see on the right of that slide is the malignant cell that is felt to be associated with that normal cell. And so if something goes wrong during the development of this lymphocyte, at various stages of that development, that's where you can see the corresponding cancer, the corresponding lymphoma. And it's interesting when you look at this to see that early on in differentiation, you can see these very aggressive cancers such as ALL, again, typically a disease that we see in children, but is also present in adults in some percentage, as well as Burkitt lymphoma, which is, again, still an immature B cell. And then you can see the more mature B cells is where we start to see more common lymphomas, whether that's CLL, follicular lymphoma, or diffuse large cell lymphoma, as I mentioned. And what is the goal of thinking about this classification? It makes it easier for people to understand this as we think about the biology, but it also helps us better understand how to treat these diseases if you understand what pathways or targets might be relevant at various stages of differentiation. Now, when I was speaking earlier, I was highlighting that the use of genetic mutations has been one way that we've been able to take diseases that we thought fit into one bucket and start to subcategorize them. And so diffuse large B-cell lymphoma is, again, maybe an umbrella term in one way, in that we're now understanding that there are additional subtypes that can be found within this broader disease of diffuse large cell lymphoma. And you can see here, this is now over 20 years old. This is a heat map that looks at variation in gene expression in individual patients, where red versus green reflects variable gene expression, with red being more expression thereof. And what you can see here is this was a seminal paper from the NCI in the US that highlights 3 types of diffuse large cell lymphoma that they identified: what we call germinal center B cell type, activated B cell type, and then what they call type 3, because it didn't really fit into one or the other. So even just suggesting here that this early attempt at classification genetically did not tell the whole story. And why is this important? It was important because it identified that patients that got standard treatment, so these are all patients that received the same type of treatment, it was a CHOP-based treatment, that the outcome was different, and suggested this was then biologically important, that people with germinal center B-cell lymphoma had a more favorable outcome, and that those with activated B-cell subtype did not do as well in the older days with these types of standard treatments. Now, moving forward, what's happened? So you go forward again about 16 years, and that same group went ahead and published a different classification. And again, here, this is looking at now multiple different subgroups showing multiple different genes. And this is now highlighting, again, a classification that includes 4 groups here and many more as well, as they further subclassify based on the presence of these, again, genes using next generation sequencing. So again, a more sensitive gene technique. Why is this important? It's now in evolution that various classifications here might allow you to identify specific subtypes of DLBCL that may be targetable by very specific drugs. And so this isn't really ready for prime time yet. This is something that is still being explored in the research setting. But hopefully at some point in the future, we'll be able to come back and say, with these specific subtypes of diffuse large cell lymphoma identified by next generation sequencing, we can modify the therapy to thus personalize treatment in a little more elegant way than what has been done to date. What's happening in the clinic, though, is that we also use other markers, not just cell of origin, so not germinal center and activated B subtype, but we also look at specific genes, and in this case, 2 very important genes in lymphoma, MYC, MYC, as well as BCL2. And these are tests that are readily available in the routine clinical lab and are frequently done in patients internationally as well as in Canada, because we do potentially modify therapy based on the presence of this. And this slide is really to show you an interesting observation, and maybe why cell of origin, which is something that gets reported typically on a pathology report, is maybe less important from a decision-making standpoint, because you can see by looking at the presence of MYC and BCL2, the presence of MYC and BCL2 really drive a lot of outcome in terms of predicting how patients do, whereas the cell of origin appears less important when you layer MYC and BCL2 onto this. We'll come back to this and its clinical implications in a couple slides from now. So from a diagnostic standpoint, it's important to realize a couple of things here as a take-home. Lymphoma is a common diagnosis. So I mentioned at the beginning, this is the sixth most common cancer in Canada, but there are multiple different subtypes. But the most common ones, things like diffuse large B-cell lymphoma or follicular lymphoma, may be easily diagnosed in a routine lab at any hospital in the country. But there are more specialized tests that can be done, both to be a little more precise, but also that may be necessary in uncommon or unusual cases. And if that happens, the pathology samples might be sent to a reference center with a more experienced hematopathologist that has additional tests available in their lab to better classify the case. And this is where expert hematopathology opinion is really going to be critical in these more uncommon subtypes. And this often happens in the background with patients. And so you may just hear that the pathology has been sent out, we have the answer, or we're waiting a couple more days before we get the test results back. Obviously, it's really important that diagnosis is the bedrock that you're making an opinion on and helping design a treatment plan on. So you need to have a really good sample. You need to have a bigger tissue sample. And so this is a place where there's been constant tension, because compared to the old days where someone would go see a surgeon and have a large biopsy taken and have to go through a bigger surgical procedure, we now know in 2024, and this has been going on for at least a decade, that it's easier, potentially safer for patients to have smaller biopsies taken using interventional radiology to do this under CT or ultrasound guidance using smaller needles. So the trade-off is it's a lot easier for patients, it's a lot safer than going through a surgery, but going to the lab, the pathologist is now left with a smaller sample collected through a needle, and thus maybe in certain cases, they may not get as good a tissue sample, and they may not be as confident, or maybe unable to make the diagnosis quite as clearly as if they had a bigger tissue sample. So an important thing to think about. And as I've just shown you, modern diagnostics are built on using these cutting-edge technologies, and you may need enough sample to make decisions. And as I highlighted earlier, in particular, MYC and BCL2 may be very important for decision-making in the clinic today. Moving on from diagnosis, so staging and response assessment are important parts of what we do with a lymphoma patient. And so staging is that process where we determine how much lymphoma is available at the time you're assessing a patient and about to potentially start treatment. And so in the old days, it was a little easier. You would just do a CT scan. You might need to do a bone marrow aspirate biopsy. But again, over the past 20 years, things have really evolved, and there have been a couple of different iterations of how we should stage and assess patients moving forward. The most recent consensus was at a meeting that was held in Lugano, Switzerland back in 2014. And this incorporated PET scanning as being a key part of response assessment. And FDG PET, so that stands for fluorodeoxyglucose positron emission tomography. So this is a scan that's similar to a CT scan, but the difference here is that the contrast agent that's given through an intravenous is actually sugar that's been treated and now has radioactive fluorine attached to it. So again, this is medical grade radiation that is safe and allows us to better image areas that may represent lymphoma. And so here, this just kind of highlights that point. So diffuse large cell lymphoma is an FDG avid histology. And so again, the recommendation around the world is that if FDG PET CT is available, as it is in Canada, that this should be part of routine staging. And one of the things that we learned is if on a PET scan, we don't see evidence of the bone marrow being involved, that means you can generally avoid a bone marrow test. And I highlight that this may be controversial, but it's controversial only in a couple of cases. So if someone has abnormal blood counts and the PET scan doesn't show bone marrow involvement, if you don't have another explanation, the bone marrow test may still be needed. And if this is happening in a patient where we have another type of lymphoma or another type of cancer in the background, or the bone marrow had another problem in it, it may be important to do a bone marrow because in these other circumstances, the PET scan may not be as useful as it is just in a patient when we're dealing with DLBCL as the only problem. Now, if you're ever reading a PET scan report, and many of you now with our current electronic medical records will see these tests routinely, unless you opt out from that, there is what's called a 5-point scale to assess a PET scan. And again, it's called the Deauville score. Again, that's because a bunch of experts got together in Deauville, France to be able to help put this together. But what it really shows is that from score 1 to 2 to 3, this means that the PET scan is essentially reported as normal. And so that means there may be mild uptake in certain lymph nodes, but that's not brighter than the liver. And that is something that we can see that is not really typical for lymphoma. However, if the uptake is brighter, and so this means sugar is being taken up after it was injected into an area, and that's brighter than the liver or much more brighter than that, that is often consistent with the presence of lymphoma in that area. And now it's important to recognize, much like a CT scan, so these are pictures, they don't tell you with 100% certainty that any area shows lymphoma, but if it fits with the presentation, if it fits with how the patient's feeling and what we see, then generally it's consistent with the presence of lymphoma. If an area doesn't fit or doesn't look or is unusual in its appearance, then the clinicians looking after a patient will need to think about that and may either need to do a biopsy or do some other tests to try to determine if that area is actually lymphoma related or not. And what other things might cause abnormalities on a PET scan? Well, the first and most obvious one is infection. So if someone's had a cold or a flu, or if even someone has had a vaccination for some reason, and then they go on to have a PET scan a few days later, you might pick up changes in lymph nodes that reflect, again, recent infection or active infection, or even something as simple as a vaccination, because the lymph nodes under the arm on that side might light up because the immune system has been stimulated by a vaccine. Yeah, so as I mentioned, PET scanning has become a gold standard in diffuse large B-cell lymphoma, both for staging as well as for response assessment. It is important to recognize that it may not be always feasible to get a PET scan quickly. And so in someone that's very sick, a CT scan and the information that you have may be enough, and it may be important to give somebody some treatment, and a PET scan may be a test that doesn't happen in someone that's quite sick, and starting on chemotherapy becomes important. And it's also important to recognize that in certain areas, and that may be away from larger metropolitan centers, certainly like Toronto, access to a PET scan may not be as quick just because local hospitals may not have it, and it may be a more regional center where these tests are available. Now, just to highlight something from a decision-making perspective, it is important when we're thinking about therapy to really think about our goals of care. There are standard therapies that are available in lymphoma, and they are highly effective. It is important to recognize not all lymphomas are treated the same way because the goals of treatment may be different. And again, in diffuse large cell lymphoma, generally the goal of therapy is cure. And we may need to modify our treatments based on a specific patient, based on other medical problems or fitness. And so when we think about this, as we craft a treatment plan for someone, we modify specifically to meet some of these individual needs in a patient. And this is potentially balancing side effects or toxicities against effectiveness, and recognizing that if someone may not be well enough to get the full standard treatment, it still may be reasonable to pursue that treatment, but we need to modify it somehow, whether that's minimizing certain doses of drugs or maybe limiting certain drugs in theory. At the bottom of this slide, I'm making a point about remission versus cure, and I think this is an important thing to highlight now. I'd mentioned the goal of treatment for diffuse large B-cell lymphoma generally is cure, but you'll notice when we think about giving treatment and finishing a treatment, our goal is to achieve remission. And remission means generally scans are normal, or that a PET scan is normal. And that's a snapshot to say, can we detect cancer? Can we detect lymphoma in a patient that's finished treatment? And so if the answer is no, you are in remission, or maybe more specifically, you're in complete remission. And if complete remission is maintained over the rest of someone's life, then that becomes cure. And so that's a difficult thing because it's dependent on time. The longer someone stays in remission, the more likely someone's cured. We can't predict the future for everyone. And so, again, the longer someone stays in remission, the better the likelihood is that someone's cured. But it becomes difficult to use the word cure because there is the potential of relapse in the background. We know with diffuse large cell lymphoma that someone who's in remission for 2 years is more likely to be cured. And by 5 years, this magical 5-year mark, which in many curable diseases is mentioned as an important benchmark, it's because the likelihood of a relapse, again, substantially drops off after the 5th year, and thus we're increasingly confident in a curable disease that cure is hopefully likely to happen. Now, again, I'd mentioned earlier with indolent lymphomas, we don't necessarily cure the disease, and it's important to recognize if you're talking to other patients or other family members or friends have experience of having dealt with friends or colleagues that have also been treated for lymphoma, the way we think about indolent lymphomas, such as follicular lymphoma, is very different. And these are diseases where there are incredibly effective therapies. People may do incredibly well for decades, but in aggressive lymphomas, whether that's diffuse large cell lymphoma or even Hodgkin's lymphoma, we think about cure as the main driver for decision making. And it's important to recognize when talking to other patients that they may be, if they have a different disease, they may be approaching it from a very different standpoint in terms of treatment philosophy. Now, we're going to get in and talk a little bit about some of the treatments that are influencing how we do things in 2024 in Canada. And I think it's important to mention rituximab. Now, rituximab isn't a new drug, but it is one of the bedrocks upon which therapy has been built. And it is one of the original immunotherapies that has been given in cancer. So rituximab, anything with a mab at the end, is a monoclonal antibody. So again, antibodies are therapies that target specific markers on the outside of a cell. And so in this case, the target is CD20. What is CD20? So CD20 is found on all normal B lymphocytes. If you think about that development of a lymphocyte growing from a very early cell to a mature B cell, you may lose it at some points in development, but for most B cell lymphomas, this is a universally available target. And so the mechanism of this, the antibody binds to the cancer cell on the outside. It does make chemotherapy more effective. It may bring other parts of the immune system into play in terms of killing cancer cells directly using the immune system. And so I'll show you some of the data that's led to the use of rituximab, but it is used very routinely in B-cell lymphomas that express CD20. So this is a typical marker that is tested for by labs when making the diagnosis of diffuse large cell lymphoma, but generally has no role in diseases that don't express that marker. So T-cell lymphomas, or very typically Hodgkin lymphoma, do not express CD20. Now, this is one of the big studies that led to the change of how we manage lymphoma. And so CHOP was a gold standard back in the 80s and 90s, and it was really the addition of rituximab that changed the field. And this is the original study, now published 22 years ago, that showed that adding rituximab to CHOP improved the cure and the overall survival for patients with diffuse large cell lymphoma. And this was a study in one of the more challenging groups of patients at that time, patients over the age of 60. Now, the other components in this include the other 4 drugs which are in CHOP, and that's cyclophosphamide, hydroxydoxorubicin or doxorubicin, oncovin or vincristin, and prednisone. And so here I've highlighted a couple of the side effects that are really relevant for this regimen. So with rituximab, the most common things are infusion reactions. So when you're getting the drug, this could be mild fevers, chills, or shakes. More significant reactions such as major allergies or anaphylaxis, like what can happen with a peanut allergy, are incredibly rare, but can happen. With CHOP, the things we tend to think about are nausea or vomiting being common, potentially the risk of fever. Again, the risk of fever, worrisome for infection, more common in people as we get older. So over the age of 60, that's a risk that we tend to try to minimize with the use of drugs such as Grastafil or Neupogen to reduce the risk of infection. Peripheral neuropathy, so numbness or tingling in your hands or your feet, and potentially the risk of heart injury, which is dose dependent. Again, we typically give 6 cycles of this treatment. The risk for heart injury goes up with 9 doses, and so we generally never get to that threshold. But this may be a reason why we often do some heart testing before we start chemotherapy like this in the majority of patients. And so R-CHOP has been a gold standard, and it's now been a gold standard for 20 years. Now, we may vary our use of R-CHOP in a couple of circumstances. And so firstly, we often use a slightly more complicated regimen, and it's called dose-adjusted EPOCH-R. And so you can see the initials DA EPOCH-R there. So the R, and you can see in EPOCH the letters that make CHOP. So 5 of the drugs are similar. There's the addition of a drug called etoposide, which is also given intravenously. And so this is a drug regimen that's a little more complicated because we may give some of these drugs infusionally over 5 days. And in some clinics or hospitals, we're able to do this with a pump, where patients may go home with a pump, come back to the hospital the next day and have it changed, and so receive chemotherapy over the course of a few days, coming back and forth to the hospital. Some groups do admit people to hospital to be able to give this regimen. We use it in a subgroup of diffuse large cell lymphoma sometimes called primary mediastinal lymphoma. We sometimes use it in double hit lymphoma. So again, that's if MYC and BCL2 are more involved. I'll show you a little bit of data about that. It does come with some more side effects, and so it is a regimen that we may not use as much in people if they have other major medical problems or get above the age of 70 or so. The other thing where we may modify a treatment like R-CHOP, again, is in patients over the age of 80 as an example, or potentially over the age of 70 as well if they have other major medical problems, and we might modify the dose. And so when we get into some of the details of these populations, I'll just show you a couple of slides here. And this is the story about what we call double hit lymphoma. And so this is the lymphoma has genetic alterations in those 2 markers I was mentioning earlier, in MYC and BCL2. And what you can see on the left was some of the more worrisome data where we saw that people were less likely to be alive or cured getting standard treatments compared to other DLBCL patients that did not have these abnormalities. And so again, a group in the US looked at their patient outcomes retrospectively and had showed that if you gave more tough chemotherapy, and so by this they meant intensive induction, patients tended to do a little bit better in terms of disease control. And that led many groups around the world to switch to that more aggressive dose-adjusted EPOCH regimen. What you now see on the right is that the outcomes look much better in the modern world. And though it is prognostically significant, we see even with R-CHOP-based treatment, looking at the red curve, the outcomes are much better over time than what were described in this data set now about 10 years ago. And so practice is starting to change, and now we are seeing R-CHOP potentially being given in this patient population, though many groups, including ours, still continue to use dose-adjusted EPOCH-R unless people have some very favorable features in their diffuse large cell lymphoma, such as being stage 1 or stage 2, or if there are medical issues that may limit the ability to give this chemotherapy due to concerns about side effects. These are the original data looking at dose-adjusted EPOCH-R in primary mediastinal lymphoma, and you can see the results are excellent. It looks like it doesn't fail in anyone, and so we know in smaller studies where, again, patients are likely very selected based on how they may get to a specific hospital, that results may look very good. But these are the data that really highlighted the effectiveness of this regimen, and one of the reasons that many groups will potentially use this regimen or R-CHOP in this setting. The other key advantage with the use of dose-adjusted EPOCH-R is if we're concerned about the use of radiation in this patient population. This regimen does not typically build in radiation as part of the treatment. And so, again, where I tend to favor the use of dose-adjusted EPOCH in primary mediastinal lymphoma would be for patients where the feasibility of radiation is going to be pretty low, and that may be based on how their scan looks at the time that we're starting treatment. If the disease is in areas where we might have to radiate areas close to the heart or other important organs, this would be a reason to look at an alternative such as this. And lastly, in older patients, just showing you here that a group in Europe did a very important study where they showed that by starting patients with some oral treatment, even prednisone, which is part of the components of CHOP, before starting people on intravenous treatment, you're able to lower the likelihood that people may die from side effects starting treatment when they're older and potentially have a lot of other medical problems. And this has really led to a practice change now for more than 10 years, where many groups will start with prednisone, maybe even start that first cycle of R-CHOP at reduced doses for a couple of the drugs. And these are data from the French showing that in patients above the age of 80, if you modify some of the chemotherapy, it can be given safely, and you might have the potential to cure even patients over the age of 80 with this type of treatment. Now, where are we today? So I told you that R-CHOP had been the gold standard in Canada and again, the world for 20 years now. Could something finally beat it? And so there's this study, which was now published a little less than 3 years ago, looking at the addition of another antibody. In this case, it's a drug called polatuzumab, replacing vincristine and then still using the other components of R-CHOP, in this case RCHP. And this was an improvement and showed an increase in the cure rate in patients with diffuse large B-cell lymphoma by about, as you can see, 6.5%. And this was a trial that was done in adults up to the age of 80 in patients that had 2 or more risk factors for their diffuse large B-cell lymphoma. So the patients that had 0 or 1 risk factor generally have a very good cure rate with R-CHOP, and so they weren't included in this study. Now, this trial was a positive one and the first to really move the bar forward in terms of building beyond R-CHOP. And this is a new standard, but is not being uniformly used around the world. Now, there are many countries where this has been approved and it's publicly available. So it's publicly available in the UK, it's publicly available in the US, some other countries around the world. Health Canada has approved this treatment, but unfortunately, none of our provincial payers has approved this treatment. And so this has created a bit of an awkward situation where we know we have a slightly better treatment that is available for patients, but it isn't publicly funded. And so, again, in my own practice, if this was a treatment that my patient might have been eligible for based on these data, I sit down and discuss it with patients, and there is the opportunity to potentially obtain this drug if people have a private drug plan or other things. And again, there are many people across the country that are still trying to work to bring this drug to public funding, but it is an important option that may be available to patients. Now, that's a quick tour through the primary treatment of DLBCL. Again, in general, compared to many cancers, the treatments are excellent and the outcomes with cure rates are very good. As you can see, they were above 70% there, and so that's a good number. I've highlighted some of the areas where treatments may vary based on specific circumstances. Again, if it is a specific subtype of diffuse large cell lymphoma, such as primary mediastinal lymphoma, or again, if patients are older or have other medical issues, or again, if we're dealing with this double hit lymphoma with MYC and BCL2. In the interest of time, I'm not really highlighting how we may use radiation, but again, in localized disease, if it's stage 1 or stage 2, radiation still may be an important part. And again, when thinking about other areas where this could be, if this shows up in the brain or the spinal cord or the spinal fluid, we use some, again, other more specific treatments, or we may give treatments to prevent the development of lymphoma in the brain or in the spinal cord or spinal fluid. And again, in the interest of time, I'm not dwelling on that, but happy to speak to it if it comes up as a question. Now, the last part of this talk, I'm going to tell you about some of the things that are available in the relapse refractory setting. And as I said, if the cure rates are roughly about 70%, that may mean 30% of patients, or a little bit higher depending on the risk group, may unfortunately have to deal with DLBCL that comes back or is present after a treatment like R-CHOP. It's always important to be as confident as you can that you're dealing with active lymphoma, and so we generally recommend a biopsy in all people to document this. Again, the type of lymphoma may change, and that may then say a different type of treatment may be available. And you just want to be sure that you're not treating pictures on an X-ray or a CT or again, a slightly bright spot on a PET scan. You want to be as confident as you can that it is actually lymphoma that is no longer in remission. And these treatments may vary based on the fitness of a patient. Again, if they're younger and don't have other major medical problems, we may be able to go down the road of more aggressive treatments. And again, there is in diffuse large cell lymphoma now the potential to cure a patient after first treatment with at least 2 different options. And so the gold standard for a long time was the use of stem cell transplantation, and in particular, autologous stem cell transplantation. And by this, we mean that stem cells or young bone marrow cells are actually collected from the patient and then are infused back into the patient after we've given someone high-dose chemotherapy. And so in this setting, the high-dose chemotherapy is used to wipe out any residual cancer cells after someone's received chemotherapy. But the consequence of giving high-dose chemotherapy is we wipe out normal blood cells in the normal bone marrow system. And so how do we get around that? We have the young stem cells that we've collected from a patient. We can give them back to someone through an IV and essentially function like a blood transfusion. And then over the course of a couple of weeks, those cells are smart enough, they're able to home back into the bone marrow and start producing a new bone marrow system. And there was a lot of work that went into this in terms of preclinical studies to be done in the lab and early clinical trials that showed feasibility and safety. But this is a study, again, a hallmark now, yeah, if you can believe it, it's basically 30 years ago, where, again, investigators in Europe showed that a stem cell transplant improved the likelihood of cure and survival over the use of conventional dose therapy. And this was really the bedrock that second-line therapy was built on, the PARMA study. What happened thereafter is people looked to explore the type of chemotherapy that we could give as a lead into the transplant. And in order for transplants to be done, chemotherapy needs to be successful from a standard dose standpoint, though again, we use different regimens than CHOP. And the gold standard in Canada very quickly became GDP. This is a 3-drug regimen using the drugs gemcitabine, dexamethasone, so a cousin of prednisone, and cisplatin is the P. And what we did in the trial that was run by one of my colleagues, Michael Crump here in Canada, was that GDP was just as good as the gold standard that was used around a lot of the world called DHAP, but it was far better from a side effect standpoint. We looked at quality of life. Quality of life was far better for patients receiving GDP than the other standard of DHAP. It didn't need to be given as a hospitalized 3-day treatment. It could be given in the outpatient setting. Side effects, as I mentioned, were better. It was a cheaper therapy, even though it was just as effective. And so this led to its approval and usage quite broadly in Canada. And now it's being used in a number of other countries for the reasons I mentioned to you earlier. And so this is a tough treatment, and we know that because we're giving high-dose chemotherapy that it will not be available to everyone, because as people get older, particularly over the age of 70, it becomes tougher to do these things from a safety standpoint due to the risk of death or major toxicities. And it is important to highlight that if chemotherapy, standard dose chemotherapy doesn't work, this type of treatment really isn't going to benefit someone. And unfortunately, the best that chemotherapies may work leading into a transplant, it's only about 50% of patients have disease that responds well enough to go down this road. And then the price of recovery from a transplant, it can be a very tough thing, frequently requires hospitalization, though again, many groups are now able to do this in the outpatient setting. But the recovery time after a transplant may be, 3 to 6 months on average. Now, other therapies have come along, and it's important to highlight, again, this type of cellular immunotherapy, so what we call chimeric antigen receptor T cell or CAR T cell therapy. And this, again, takes cells that we collect from the actual patient that has lymphoma, and this time they get engineered to be able to target a specific marker on the cancer cell. And so very similar to monoclonal antibodies, the target here isn't CD20, the target in this case is CD19, which again is a marker that tends to be expressed on the majority of B-cell lymphomas that we look after. Now, in how does this work in routine clinical practice? So as mentioned, cells are collected from a patient, that's called leukapheresis. Steps 2, 3 are where this happens in the clinical lab. So the cells are then manufactured and then grown, and then they're shipped back to a center such as ours, where these cells are then ready to go. We give a little bit of chemotherapy to prepare the immune system for the patient, and then again, these cells are infused just like a blood transfusion or just like a stem cell product, and then they do the work, and these cells actually bind to cancer cells and help to kill them. Now, what did we learn from doing some of the studies in this setting? Like any other therapy, they can come with their side effects, and these include risks from the stem cell product, because again, this is a genetically modified product, and so we need to watch for the consequences of that. We can see immunologic side effects, and so this may be called cytokine release syndrome, where we can see fever, low blood pressure, maybe the need for oxygen, and these are toxicities that usually happen within the first few days after the cells are infused. We can see difficulty with neurologic symptoms, and this can run from as simply as people have some difficulty writing to being confused or even having seizures. And again, these side effects tend to happen early. We can rarely see allergy or, again, major allergies such as anaphylaxis to these products, but we also see the risk of infection because these cells and the chemotherapy can also deplete the immune system. And this is, again, a risk of infection that may go on for many months after the product is given. Why is this important? Well, again, investigators a few years ago did a study now that shows that CAR T cell therapy beats our gold standard of chemotherapy and a stem cell transplant. So that's the standard of care in red. And the people that had a stem cell transplant are actually more likely to be alive and in remission, but also now we know to be more likely to be alive if they receive this type of treatment. And this is using one of the products. In this case, it's called Axicell, and the study was called ZUMA-7. And so these data have been available, and again, this treatment is available as a second-line treatment, again, in many countries in the world. Health Canada has approved this, but much like I mentioned with polatuzumab, this wasn't a no in terms of funding. This is a yes, we're waiting for the funding to be implemented, and I'll say it's been a little frustrating to be waiting for this now for a couple of years, but we're hoping that, again, this will be available imminently so that we're able to use this in the second line setting. It's important to acknowledge that this is now publicly funded and has been for a few years now as a third line treatment. And again, this is follow-up from one of the studies there that show in a group of patients that used to be incurable with standard therapies, CAR T cell therapy in the third line setting now can put up to about 40% of them into long-term remission, which after 2 years does really appear to be cure, with follow-up of some patients now beyond 5 years after treatment and doing well. And so this was a treatment that access was limited as CAR T centers were being set up and opened in many provinces, but now most provinces have this available or have relationships with other provinces close to them where they're able to get these treatments for patients in Canada, unfortunately as third line, hopefully now for second line for the patients that need them as well. And so, as I mentioned, it is currently standard as a third line treatment. There is some variation province to province between access, and maybe the criteria for specifics around patients may vary a little. We now do have three products that have Health Canada approval, and there are many clinical trials that are ongoing to try to optimize and improve on the outcomes that I've shown you in the past few minutes. Now, what else is available? So for patients that are not able to go to CAR T for whatever reason, or not available or not able to go through autologous stem cell transplant, what other options are available here? And I'll highlight two options that may be available in Quebec or in the rest of the provinces, depending on the patient's circumstance and where you live. So that antibody polatuzumab was initially developed in relapsed refractory patients, and so in combination with bendamustine rituximab is now available in most provinces across the country based on these data that I've shown you here that were published by our colleague Lori Sen, who is out in British Columbia. Tafasitamab and lenalidomide. So tafasitamab is another monoclonal antibody, and this is given in combination with this pill, lenalidomide, and this is a treatment that is publicly available in Quebec, where polatuzumab is not funded. This is a treatment that would be available for these types of patients. And so just highlighting there are a couple of different options here that are now available, and good options compared to our older standard treatments with traditional chemotherapy that may still be available everywhere if needed. And the other thing that I highlighted there, we'll get to bispecifics, which are now a newer class of treatment. But before we get into that, it is important, as I mentioned earlier, to say that there are other things that may be available depending on the circumstance a patient is in when we're dealing with relapsed refractory disease. This may be oral chemotherapy that's very easy to give and simple from a side effect standpoint. Intravenous therapies, there are other single agent chemotherapies that we sometimes use. Radiation can also be a good consideration here, whether that's for a site that's got symptoms, whether it's causing pain, or if you're worried about the relationship of an area of lymphoma in relationship to a major organ. These are sites that may be very amenable to radiation as a way to deal with a specific site of disease. It's important to recognize that when we're not thinking about stem cell transplants or CAR T cells, that we're recognizing that curative intent therapy has largely been limited to those settings, though I'm now going to talk to you again about another treatment we're very excited about called bispecific antibodies. And so you've gotten a sense that antibodies are therapies that are used very commonly in lymphoma, and we've had a lot of success. This is a different concept, but at least the principle is similar in that we're trying to target a marker on the cancer cell, and in this case, it could be CD19 or CD20. And by bispecific, what we mean is that these antibodies have two ends, and the other end typically targets CD3, and CD3 is found on your normal T cell. So the idea here is, can we bring a patient's T cell to the tumor with the idea that the T cell will help to kill the tumor? So again, similar to what we're doing with CAR T cells, but here we're not engineering cells, we're using cells that are present in the body already and using this antibody to bring them to the tumor. And so Health Canada has very recently approved two bispecific antibodies, so epcoritamab or glofitamab, and they're both indicated in very similar patients. So this is as a third-line treatment, and these are as single agents in patients that have either received CAR T cell therapy or are unable to receive it, and that could be because treatment hasn't worked or the patient may not be a good candidate for CAR T cells for whatever reason. And this would also be available for patients that have received CAR T cell therapy, but unfortunately the disease has come back. Now, just as a quick summary slide, so the two studies that led to the approval of this were both looking at the drug as a single agent, these drugs as single agents, in about 150 patients or so, and show very similar data, that about 40% of patients achieve a complete remission to this type of treatment, and a good proportion of those patients continue in longer-term remission following that. The important thing to recognize with these drugs, glofitamab is given for a fixed duration, potentially 8 rounds of treatment, and then would stop, whereas patients with epcoritamab might continue on that treatment for multiple doses, even if they are in remission, until it either potentially causes side effects or stops working. Now, bispecific antibodies come with many potential risks, and some of the risks are very similar to the ones I was mentioning with CAR T cells, such as cytokine release syndrome or neurologic side effects, which we think are related to activation of the immune system. It also requires very specialized care in terms of having good algorithms for managing infection, managing the administration of these drugs, and monitoring the side effects. And so many clinics, many hospitals are now setting up to be able to give this to patients. Bigger centers or centers that had CAR T cell programs already or had done clinical trials have probably set these up and are maybe a little ahead. And I'll say many groups are sharing the knowledge that we learned from doing those earlier studies with other groups to help make these more available and easier to access for patients. So these are potentially available compassionately and should be publicly available, hopefully in the very near future. And so, as I highlighted, there are side effects we need to be careful for and to look at. Expertise is developing at many of the other centers around the country. And again, this is an exciting time for this new class of drug. Additional studies are coming, more data is coming. This very much is a work in progress, and hopefully you'll have other speakers or other information about this in the near future. And so, in summary, for relapsed refractory diffuse large B-cell lymphoma, a group of patients can be treated with curative intent, whether that's a stem cell transplant or CAR T cells. We're optimistic that hopefully bispecific antibodies may also potentially be a curative treatment. Time will tell there as we get longer follow-up from some of those studies, and hopefully we'll be able to say the same thing there, but it remains a little early. The decision-making can be a bit complicated here, given that there are some options, as I mentioned, and treatment options, again, are individualized when sitting down with a patient and seeing their specific fitness, their goals, and what may be really practical. And so to conclude in this deep dive in DLBCL, so it's about 50 minutes, it's really hard to get into everything, but hopefully I've been able to highlight some of the changes that we've seen in the field diagnostically, from a staging and response assessment, and really to highlight some of the changes from treatment. More options are becoming available. There are lots of clinical trials available across the country, and there's a lot of research that, again, patients play a very important role in to better understand how best to use these treatments, how to continue to improve them. And so with that, I'm happy to stop, and I guess we have a couple minutes for questions before our time comes to an end. So thank you very much.
Thank you. If you don't mind advancing the slide, that'd be wonderful. Thank you so much. So I just really want to say thank you, Dr. Kuruvilla, for sharing both your expertise and your insight with all of us today. I found it particularly interesting to see the progress made around medical diagnostics and treatments and how it's evolved over the years to improve outcomes for DLBCL. So very insightful. It is now time to kind of change gears a little bit for our question and answer period. If you haven't already done so, you can pop in the question and answer box in your Zoom webinar panel at the bottom of your screen. And we'll, as I mentioned a little bit earlier, that due to the large number of participants on the call and our limited time, we'll be able to get to a few questions today. And we did mention that Dr. Kuruvilla can't answer specific questions about a person's health history or status, but we're happy to follow up afterwards as a team with some of those questions you may have. All right, so I'm just going to take a quick look at some of the questions that we have, and I'm going to go to one that was from earlier on in your presentation. You talked a fair bit about PET scans. If somebody's already started or initiated chemotherapy, are they still able to do a PET scan? And what would be the benefit or kind of the challenges around that?
Yeah, for sure. So just to briefly answer the question, so from a staging standpoint, if someone has started treatment, doing a PET scan won't be helpful to stage the disease after people have had chemotherapy. But the other important point, and apologies if it wasn't clear in the presentation, a PET scan is incredibly useful to be able to understand response to treatment. And so you'll definitely want to see a PET scan at the end of treatment.
Excellent. Thank you so much for clarifying that. The other question we have here is there a connection between chemotherapy treatment for DLBCL and thickened spinal cord dura?
Okay, so that's a very specific question. And again, the theme there, so around the spinal cord dura, we're worried about, as I mentioned earlier, the potential of having involvement of the nervous system in this case. And so we do routinely use a different chemotherapy that is able to treat the central nervous system, and that is a drug that may cross the blood-brain barrier. So again, the body is designed to protect the brain and spinal cord, so we need to use different chemotherapy regimens. And so there are treatments that we can use to do that as well. Now, in order to assess this, you may need to do an MRI to look at the spine or to look at the brain. And so there is some complexity in sorting out the details there.
Mm-hmm. Excellent. Perfect. Thank you so much. I appreciate all these great questions. I think we'll have time for one more question. So our last question will be, are studies assessing biospecific antibodies in primary care today?
Okay, so I think that's one of my former colleagues and mentors, actually, Dr. Quirt. So very nice to hear from you. And so yes, there are currently frontline studies looking at the combination of R-CHOP with bispecific antibodies being compared against chemotherapy. So those trials, one of them has almost accrued, one of them is currently open. Many centers in Canada currently running them. So again, for patients, if you are undergoing frontline therapy, this is a study, or these are studies that may be discussed with you if they are available.
Mm-hmm. Perfect. Thank you. So looking at our time, I want to just take another moment just to thank you so much, Dr. Kuruvilla, for your time today and sharing all of your expertise and knowledge with us. We're very fortunate to have you in Canada supporting the population. So thank you again so much for your presentation. I'll just get you to advance the slide for us. We'd also just like to take a minute to thank Gilead, a Kite company, for their support in making these events possible. Next slide, please. And we will be presenting our third edition of the National Virtual Leukemia Conference, taking place in November, between November 4th and November 8th, 2024. You can scan the QR code on the slide, or you can visit bloodcancers.ca/leukemia conference for all the details. We'd love to have you join and learn more and have more insight into different diagnoses and blood cancer types. Next slide, please. And I just want to remind you that we are here to help you. You can reach us by email, by visiting our website at bloodcancers.ca, or by calling our toll-free number. Please take a few minutes after the call to provide, as you'll receive a short survey that will be sent to all participants after the presentation. We'd like you just to take a moment to respond, as it helps us with planning our future events and online webcasts. And we'd like to take a special moment to thank all of you for joining us today. Please take good care of yourself.